Good afternoon and welcome. Thank you for joining us today for our training, Understanding Substance Use Disorder Related to Nursing Facility Residents, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. And now, I am happy to introduce our presenter, Dr. Jen Azen. Dr. Azen is a general internist who has practiced in both the primary care and post-acute care setting. Her primary care practice is focused on geriatric patients. She provides in-home visits to medically fragile patients in private homes, adult families, homes, and assisted living. She currently works in post-acute care with Harborview Medical Center's Bed Readiness Program, where she cares for patients with substance use disorder. And now I'll turn it over to Dr. Azen to begin the presentation. Thank you.
Thank you for the introduction. I'm so happy to be here. And for all of those who were affected by the hurricane, my thoughts are out with you. I went to medical school in Galveston, so I know that firsthand. I now live in Seattle at the University of Washington. This is a picture of the skyline on New Year's Eve this year. One financial disclosure is my husband's a CVS pharmacist in home infusion and has employee stock. So objectives today, we want to understand barriers to care that residents experience in healthcare and in skilled nursing environments who struggle with substance use disorder. We want to review epidemiology and neuropathology. I will help you differentiate between substance use and substance dependence, as well as substance use disorder. Help you learn language that reduces stigma and builds a therapeutic alliance with residents, and gain an understanding of how treatment works in substance use disorder. Here's a photo of Diablo Lake in North Cascade National Park here in Washington. So many of you know that the epidemiology of substance use disorder is quite staggering, and we are really in an epidemic of overdoses with a dramatic rise, particularly since the pandemic. And fentanyl has really driven a lot of this increase in overdose deaths. This previous data was from previous years, but this is most recently up to July 2023, and you can see the trend is really not getting better. So we're really just seeing the beginning of it, unfortunately. Substance use disorder is seen in the emergency departments, and we think about opiate use disorder, but there are many other substances. And really in emergency room departments in 2022, almost 50% of emergency room substance use disorder was related to alcohol, which is by far the most common substance use disorder in our country. Opiates were second in line, and cannabis was third, with methamphetamine following. And our residents in skilled nursing environments are not immune from this. So we are really seeing a dramatic rise in men over age 65 with overdose deaths, as well as a rise in women. So we will start seeing it more and more in our facilities. So patients with substance use disorder have tremendous barriers to healthcare. It starts even in the community. So there's limited access to substance use treatment, and patients and people with substance use disorder really do avoid going to the doctor. They're not really good at making a doctor's appointments and following up on it due to all of the dysregulation in their life. And so most of the time when they're presenting to healthcare, they have a very delayed advanced stage diagnosis. So we have a lot of misdiagnosis and delayed diagnosis, sometimes because providers are blaming everything on the substance use, and sometimes because the patient isn't showing up. So when they do get to the hospital, they're often fearful of what they're going to experience in the hospital because they're concerned about going through withdrawal in the hospital. And they often have difficulty with staff, providers. They feel like their pain is under assessed and under managed. And there's quite a bit of bias really still in the healthcare system. So when they're then referred to post-acute and long-term care, there is sometimes specific discrimination against patients with substance use disorder. So sometimes in the referrals, we'll see can't accept patient because of substance use disorder, even if it's being treated and it's stabilized. And there's also limited substance use disorder training for staff. So we're trying to change that today. And there's limited access to medication-assisted treatments. So the access that the DEA has had for buprenorphine and methadone for opiate use disorder has been quite limited. They've opened it up for buprenorphine, but methadone still has a lot of limitations that make it difficult in a skilled nursing environment. So 87% of people with an opiate use disorder living in the US do not receive treatment. Not all of those 80% want treatment, but many do and don't feel like they have access to it. So I love this photo because this is how I feel many days. This is a picture of my niece driving home after many months away at a job, and she ran into tumbleweed in West Texas. And she's got her thumb up like, let's go. So that's how I approach work every day. It seems daunting, but we can tackle it. We can move the tumbleweed out and keep going. So how do we do that? We need to understand substance use disorder as a disease and not as a moral failing. And so understanding it as a disease really helps us be present for the person that's experiencing this disease. And then we need to meet people where they are in their recovery process. Lead with compassion and kindness, understand their goals, and help guide residents to with boundaries to meet their goals. So not all substance use is a substance use disorder. The DSM has categorized it under kind of 4 different areas of impairment. So loss of control over substances, wanting it, using it more than intended, cravings that are impairing their daily life. Social impairments, so interference with obligations, stop going out with friends because they're using, having interpersonal relationships, so losing a relationship, losing a job, having legal issues, and then we have health impairments. So we're going to see a lot of these health impairments, but that includes using in hazardous situations such as driving, and continued use despite those issues. And then need to increase. So this is kind of the dependency. So sometimes people have dependency, but they don't have these other parts. So they may need to increase their use or have withdrawal, but they don't have the other impairments. So a good example is alcohol. I mean, many of us know people who use alcohol, or you may use alcohol yourself and not have this loss of control or social impairments. But if you develop physiologic impairments, if you start to need increased amounts in order to get the same effect, you start moving into a mild disorder, and then even over time can become a severe disorder. So there's a big range, and we need to be careful when we're giving diagnoses specifically for treatments, that we're careful with the language and understand the difference. So quickly and go through the neurobiology of addiction. When people use a substance, that dopamine pathway gets lit up. So that's the reward pathway. It gives us pleasure, and also contributes to compulsion. So you do something, you get a dopamine surge, it feels good, you want to do it again. And then also substances do involve the serotonin pathway, which impacts mood, memory, processing, and cognition. This is kind of a general example of how substance use works. So there is this executive function that is impacted by the person's preoccupation and anticipation of use. So they're thinking about using, they're craving, then they use, and they have intoxication, which improves this incentives. So they get an incentive for using, feel better, and then there's a withdrawal and you get the negative fix. So that's called a reward deficit. We're often meeting the residents when they're having this reward deficit. So this happens in a short term, use, have a positive effect, and then have a reward deficit. But that reward deficit can really linger for a long period of time. And the only thing that really in this cycle improves it is to use again. So that's where the compulsion and the addiction process happens. So how do we build a therapeutic alliance with residents with substance use disorder? So I really think of addiction as someone being out in the middle alone. So this is a photo of a suspension bridge that's in the middle of nowhere, really. My mother's from a really tiny town in the middle of Texas. So you go to that tiny town, you drive out another 10 minutes, you get on a dirt road, you drive another 10 minutes. I think it's 8 miles in or 4 miles in. And then you see this big bridge, which is quite remarkable. It's off of a dirt road. So this is on a part of the Colorado River in Texas that was a cattle crossing. And in the early 1900s, they continued to have washouts of the cattle crossing. So this bridge was built. And it's a pretty significant suspension bridge that has a wooden roadway. And it was remodeled a few years ago, and it's the last suspension bridge left in Texas. So I kind of think of addiction as that cattle crossing. So things were working okay, but then there kept being washouts. So the substance use became a bigger part of the patient's life or the person's life. And so what they need to do now in order to keep moving on in life is they need to build a bridge. And often we're asking people to build a big suspension bridge in the middle of nowhere, and kind of thinking about how to get all of that put together is really, really tough. And the person is experiencing substance use disorder also sees it, and they think, how am I ever going to get there? Because I've really destroyed so much of my life. How do I get better? So when you're meeting a resident, you really need to center yourself. And I have to do this every day. I look at the chart, I think, wow, that's a lot of destruction. Sometimes we read what's happened to bring them to us. And it can be really, really sad. And it can bring us to feel a bit of judgment. And so you have to really watch, take a break, center yourself, and remove that bias and remove that judgment, because you're about to go meet a person who's suffering. And the only way that the situation is going to get better is that they start to improve and start working on their treatment. So we also need to remember that substance use disorder is a disease, and it needs a lot of motivation to manage. I talk about it being very similar to diabetes. It's really hard to manage diabetes. You have to watch your sugar intake. You have to watch many things. And you have to avoid things that you want. And so substance use disorder is very much like that. Patients with diabetes don't want to take their insulin or want to eat cake. And it's the same thing is going on with substance use disorder. So remembering it as a disease and recentering yourself that it's a disease really helps us to meet the patient where they are. So many residents have underlying trauma related to their substance use, or maybe their childhood trauma has put them at risk for developing a substance use disorder. So really understanding how trauma has impacted their life can help us work with the resident when there's problems. So when there's emotional dysregulation. So the substances that they're using are helping them regulate emotionally. It's not a healthy way to regulate emotionally, but it works for that resident. When you take away the substance, they don't have their go-to for emotional regulation. And so there is often this hyperarousal that happens in trauma. And when they're feeling triggered, they will often have an outburst. And so really understanding that that's going to happen and figuring out a way to help manage that with the resident when they're in a calm state can be really, really helpful. So words to use when we're working with patients, with residents with substance use disorder. So we want to avoid abuse. It can be a triggering word, but mostly it's really triggering within the chart and having other healthcare professionals looking at the chart. If you look at abuse, that really stigmatizes us. Helps us to stigmatize the resident. And so using use disorder helps to reframe their disease as a disease. So when you're using a diagnosis code to describe use disorder, you would put alcohol use disorder, opiate use disorder, and often they are in early remission. 100%, I recommend avoiding the term drug seeking. It's a very labeling term, and it really does often trigger residents and people experiencing substance use disorder, because that is their largest fear, is that they're going to be undertreated for things like their pain or anxiety. And so when they hear the word drug seeking, or they sense that you feel like they're drug seeking, then you start to have a lot of issues and more behavioral outbursts. And what we really want to do is ask residents about their goals. And so often our goals are to build this magnificent bridge. So this is a bridge in Vancouver, BC. And so we think, oh, we're going to get somebody better and they're going to have this amazing life and it's going to look like this. And really, sometimes the person that's experiencing substance use disorder really needs a rope to get across the river. And that's all that they can do. That's all that they can come up with for the moment. You know, they may eventually get to a better bridge, but we need to make sure we understand their goals and not project our goals onto them. So looking for commonality and humanity with residents is really key. A lot of substance use disorder isolates people and isolates their humanity. So many people have unique skills that are ignored, and we want to figure out what are those skills and how can we help them really dig into those skills so that they can feel proud of themselves. Hopelessness is really common. So asking residents, what is your goal in 1 year or 2 years? What would a perfect life look like for you? A lot of them have not even thought about it because they've been in so much despair for so long. And that question can really bring up a lot of hope if you really work with the resident. Like, what is your goal? How do we get there? So using those goals can help us plan a path to recovery. So when we're working with patients, we want to ask, how can we help them to get to the goals? Does doing your weekly U-Toxes help you stay on track and feel positive about things? Would you benefit from connecting to a mutual support group like AA or NA? Would you want to explore a structured treatment program once you're discharged? Do you want to go to an inpatient treatment? And then do you need help? And then how do we help establish boundaries? So maybe there's a certain visitor, a cousin that they typically use with. Maybe that person's not the right person to come visit, and we can help them establish those boundaries. So really working with the patient to figure out what's going to work for them, not telling them what they should be doing. And then we want to help them establish some regular achievement. So reward is such a part of addiction that we really can use it as a mechanism to help in recovery. So looking at ways in which we can demonstrate rewards. So maybe that's a poster in the room, and when they meet a PT goal, that there's like a big star on it, or they get to spin a wheel and potentially get a prize if there's, negative U-Toxes or something like that. That figuring out little ways to show reward can be really impactful on reinforcing good behaviors. Always be clear about boundaries. So we want to utilize goals for treatment and engage residents in establishing, but we really also need to figure out exactly what the boundary is and be very clear when working with them. I really try to avoid punishment and really focus on redirection. And when you're looking at using addictive substances, so sometimes these patients have been in a trauma, a car accident, and they have pain. I often avoid using PRN meds because that whole event of the resident hitting the button, waiting on the nurse, getting irritated that the nurse didn't come in time, and then getting the medication that then stimulates that dopamine. So that whole negative experience where there's this interaction and they get frustrated at the nurse and maybe act out, and then they get a dopamine surge from getting the substance is very reinforcing in a negative way. But if you work with the resident to schedule the meds, you will have less of that interaction that can be really triggering for the resident. And then always working on what the plan is for tapering off. So quickly looking at treatment for substance use disorder, which we will get to in more detail in future webinars. Medication-assisted treatment. So I mentioned methadone and buprenorphine that we use for opiate use disorder. There's also great medicines for alcohol use disorder. Mutual support. is peer-led group setting. Support AA, NA are the most common. So those are 12-step recovery programs. There's also smart recovery that doesn't have a religious basis and is cognitive behavioral therapy based. The Smart Recovery website is great and shows online meetings at all hours. And sometimes you can get an AA or NA meeting to come to the facility if you have enough interest. Behavioral-based recoveries are really what we consider drug rehabs. So there's inpatient, but often they have an outpatient option and even relapse prevention for residents that have really gone quite a while without using. There's contingency management, which gives monetary benefit or some sort of prize benefit for residents or patients or people to stay in recovery. So going to meetings, having negative eutoxes are all things in which they get some sort of prize or money or benefit. And it's really impactful because it works on that neurobiology. Clean and sober living is a great option for our population because it's a nice transition piece. So they're in some sort of environment that's controlled when they're in the skilled nursing, and then they can move to another controlled environment that's peer-led. And they must be in a recovery program, but there are lots of great options, and people really tend to do much better in transitioning to a clean and sober environment. So substance use disorder is a growing cause of death, and it is impacting our residents greater than 65. It's a disease and not a moral problem. Really showing empathy and compassion is key. And we need to work to support the residents' goals and not our goals. And that helps to develop that therapeutic alliance. And it can work in supporting residents is key. So I would say the biggest take home is that residents can get better, and working with residents with substance use disorder can be incredibly rewarding. It's like this is the Maple Loop Trail, which is a really tough trail. You have to climb, and then you get amazing views. So it's very similar to a nice hike. And I really encourage you guys to work with patients and residents who have substance use disorder. It can be amazing. Questions? See chat.
I don't see any questions in the chat, but let's check to see if there are any hands raised. Michelle, do we have any hands raised at this time?
There are no hands raised at this time.
If you would like to come off of mute to ask a question or share a comment, feel free to do that, and Michelle will assist and allow you to come off of mute. All right, we're seeing great presentation. Thank you.
So next month, I look forward to presenting an overview of opiate use disorder related to nursing facility residents.